All right. Well, I'm Chunn with speech therapy, and we're going to enter the world of speech therapy through the Modified Barium Swallow Study. Thank you guys all for coming. We're going to learn what it is, what it isn't, and why it's important. I know you guys won't all have direct practice with doing this test, but the results of it do interest you in some way. So we'll go ahead, and I do have barium here, ice cold. If anyone wants to try some, that can be after. If you're curious what it tastes like. Not the best, but indeed part of it. It's more like chalk. More like a chalk, like on the chalkboard. That's really the texture you're going for. But don't let that deter you, though. It's actually
That's actually pretty good.
yeah. We will get started. What is a Modified Barium Swallow Study? This is the fluoroscopic imaging procedure that we use down in radiology. We have the patient come in and we visualize their swallow. The main reason that we recommend one is if there are overt signs of aspiration at the bedside during a bedside swallow eval. So seriously, the bedside swallow is just when we go in, we have our water, we have our thickened liquid, our pudding and cracker, and we're looking for coughing, throat clearing, watery eyes, anything overt that would lead us to believe that aspiration is occurring. And if we're not confident that it will... Are we back?
We're back.
We are back. Okay. Yeah, but say, did we get that first part? Or? Okay, because they just missed that. If that's the answer, number one is the bedside swallow eval. Yeah. Okay. Okay. So yep. We'll go to the next one. Hopefully this is playing. Okay, I did find an image. This is an example of what a normal one. For the most part, I haven't had a chance to fully eval. This is kind of what we want to see. I can't really freeze frame it, but you can see anatomy lesson. You got the side view. The white tube, that's the airway. And then the dark tube where the liquid is coming down, that is the food tube, the esophagus. You'll see a little, wish I had a pointer deal, but you'll see a bone right there that comes up and the flap right there that comes down. So the bone comes up, pulls down the flap, blocks off your airway, keeps it. So like you were talking about, Phyllis, with your head back, you are in fact opening the door to that airway with your head back like this. Now, if hopefully your flap closes and you'd be all right, but if your flap's not closing, then you're opening the door and you're just asking for all kinds of possible troubles. That's what we would want to see. Got a couple images here. That's once again, so that's normally we got the division there, the white tube, the dark tube. Then we have aspiration. That if we saw that, that would not be very good. That would be a bad day at the office, but we do what we can. It's gone. It's found its way. Not only is it going down the airway, but we're also looking at the amount of residue that's left behind when they took a drink. So the pocket behind the tongue, you'll see that dark spot right up there. That's called the vallicula. Fancy way of saying just the pocket behind your tongue. So there's obviously some trouble they're having pulling back the tongue to get rid of all of the drink there. And so it's pulling there as well as in the piriform sinuses, which are the piriform sinuses are right in here. So those are two images there. Okay, first thing, so this will be the next thing that we have to do after we're... That's awesome, man. That's awesome. Okay. The next thing we're going to have to do is assess for patient candidacy. If we go in and that is how they look all the time, probably not a good idea to take them down for a modified because they are not going to be able to wake up. Their head is back, mouth open posture. They're not going to be able to follow the one-step commands that we need them to do. So when we're looking for a modified, we want them to be able to follow just one-step commands for the most part. I mean, if you have to cue them a little, it's not the end of the world, but you don't want them to really just be not able to participate. Maintain the alertness for 10 to 15 minutes. That's about how long we need from them. We want to look for core strength. There's a strap on the chair down there, but if they're really slouched over, that's not going to be a great position. So we really want them to be able to hold themselves up during the exam. We mentioned something about the BiPAP or the high flow nasal cannula. If they are on BiPAP or high flow nasal cannula, they will not send them down for a modified, just for the amount of oxygen they are requiring. And then obviously we don't want them to get aggressive. We don't want them to swing at us or spit barium everywhere or do anything that's just not gonna. It's gonna be a waste of everyone's time down there if we get them down and it becomes a big show. So patients in restraints are also not accepted for an MBSS. So if we hear that they're in restraints, we'll be monitoring when they're able to come out of those before we can do the assessment. So then next we will be assembling the materials. I brought a couple of them. You got your cups, your barium, the materials you'll need, 3 cups. There's 3 kinds of barium. So there's the regular barium that's just like a thin liquid, water or tea. Then we mix Sprite in one. We have nectar thick liquids there. Think about a milkshake consistency. Doesn't taste like a milkshake, but that's about what your consistency is like. We have barium pudding that we put on the spoon, a graham cracker, and then there's a honey thick liquid on the side. I've kind of put down. It's kind of as an like not an emergency, but if we're not able to get down the other ones, we have the honey thick there too. It's just even thicker. We're really just trying to see what we can get down safely. And then sometimes you might need an extra spoon, especially if you get someone off the floor who you don't want to give them a cup and say, here, go for it. If you really think from bedside there's some aspiration, you don't want them to tump a cup back and you just visualize a lot of aspiration. That won't help anything. So you can do a spoonful trial. That way you can keep it down. And obviously a straw, because we do trials from the straw during the liquids too.
Why is it like really making stuff harder to swallow?
That's a good question. So I don't know if that would be the image to show, but essentially the thickened liquids is usually the goal of the thickened liquids is to slow the flow of the bolus, or the bolus being the drink. So if we go back to the image, which I should be able to, I have technology, yep. So when it shoots down, it goes really fast. And if they're not able, if the muscles aren't working well, then the thin liquid is more likely to get away and go toward the airway. But by making the drink thicker, you slow the flow and you give them more time to activate their swallow. So that helps them to. But so obviously we've got our materials together. Now the question I probably ask 95 to 100% of the people that sit down in the chair, what's going on with your swallowing? Pretty much. And usually they'll tell you roundabouts what's going on, what concerns they're having. And you can get a lot of information from them that the chart can't tell you, because sometimes on these modifieds we're really limited to the chart review, especially if they're an outpatient modified. Sometimes you get oral phase dysphagia. That's it. And then you have to color in the rest from what they can give you. So some examples of questions you might ask. Do you have trouble with foods, liquids, or both? How long? You want to know how long it's been going on? You want to establish a baseline diet, what they were eating and drinking before. Because if they tell you they were doing soft textured things, you might, instead of a cracker, you might soften it up with some of the liquid and make it more of a mechanical soft, a softer thing for them. So you want to get a feel for their baseline diet. And then during this time, you're also able to explain what they'll be eating and drinking during the test. I usually just do it the same way I just told you all before, going through what the liquids are, a little bit of pudding, the graham cracker. That's the case history. Once we've told them what's going on, we know what's going on, we can start giving them trials. So we'll give PO trials, PO by mouth. This is usually the order we do. I don't know if they do a different order. Most times we'll go thin, carbonated, then nectar thick, and we will do the order spoon, cup, straw. That also is for bedsides too. We usually will go spoon, cup, straw for that as we're doing a bedside swallow test. And then we go to the puree and the cracker. At the end of the test, I'll have them, because usually they're doing one sip at a time, each drink. But at the end, I usually ask them which one they drink from most, a straw or a cup. And I say, hey, take a couple of drinks like you normally would. If they've aspirated during the test and it looks like it's going to be a problem, I usually would avoid that step, because I'm not trying to fill up their airway with more drink if I don't have to. And then after that, it's an interesting test, because unlike the other X-ray imaging, we can actually go through the results as soon as they're done. And they tend to enjoy that because there's no waiting. So we We can go through the images with them. Before an MBSS, the results we're looking for primarily two things. Is the airway protected? Do we have aspiration or penetration, which we'll get to? And then are they clearing all of their bolus, which I've got there as a bite or a sip. We call that the bolus. When they swallow, is there a lot left behind? So depending on the amount of residue, where it's left behind, and how often aspiration or penetration, or the amount of that, there are certain exercises we can recommend to strengthen the different muscles involved in swallowing. That's where the results are. And then, okay, this is where you get, I just said penetration a while ago. A couple examples here of penetration. So aspiration is when it goes into the airway. Penetration is this line. Dang, bro, break the TV. This line right there, that line right there would be penetration. That's deeper penetration to where the depth it goes, there's the level and so forth. So not concerning to a certain age range. Sometimes that's within the normal limits. But if it's frequent and there's a lot of residue left behind, we still may recommend things depending on the depth and other factors like age and so forth. But moves toward the airway, but it doesn't pass the vocal folds, which in this image, your vocal folds would be right here. Kind of hard to visualize them. It's when it gets it's really just a shading more than anything, but it's just on the top of your airway. Then that's when we can get into recommendations, depending on what we see. There are swallowing exercises, like I mentioned. Sometimes it can be corrected with just precautions. Upright positioning, small bites and sips. The chin tuck, add an extra layer of protection. Diet modifications, if required. If we have to thicken the liquids while we do therapy, then that could be a temporary fix while we strengthen those muscles. Sometimes we need further imaging. Here's an example of what it's not. The Modified Barium Swallow Study is not the Barium Swallow Study. Those are oftentimes confused because they're almost the same name. I wish they'd find a way to change it, but I wouldn't know what to tell them to change it to. But the Barium Swallow Study, also known as an esophagram, that's when they come down, have them take a pill standing, and they get the whole look of their esophagus. And that is one that, for that, there are its own qualifications that the patient needs to have to be a candidate for that one. But not to get those two confused. Sometimes we have to consult the ENT. If they come in for outpatient for the swallow exam and they mention voice concerns, sometimes we have to make that consult to the ENT to further explore the structures there. And then general surgery. There are sometimes in the swallow, when there are things that we can't fix. Osteophytes, bone spurs on the spine that are out there. If we see those, we can't necessarily diagnose them. That's not in our scope of practice, but the radiologist identifies them, and then we make the proper referral to general surgery to see if we can get them out. Because or also there are cricopharyngeal bars, two examples, but really they just jut into the back of the esophagus and they create a bump, and then that's where things can get hung. And if it's something structurally there, no amount of therapy is going to fix that. Where do you come in? Also, if you made it this far, remember you are amazing. Letting that sink in a little bit. I'm not good at accepting compliments either. It's okay, but you guys are all amazing. So, that's my guy, Tobin McGuire. So, PO, where do you come in? Obviously, PO intake is important to the patient's ability to perform in therapy. We want to make sure they're well nourished, able to complete the exercises. The documentation very much assists us with assessing candidacy, how they transfer, how they're interacting with you guys. We see them in the bed, give them a couple of things, but you're getting them out of the bed. You're having them to do a lot more things to where how they perform with that will have us in our mind. Okay, how are they going to do down in radiology, getting out of the chair? Transfers, insight into how they transfer is vital because radiology is going to want to know, do we need a steady? Can we get them from the wheelchair to the chair? Do we have to full on bed slide them? What we have to do. So that documentation is very important. And just also in spreading the diet recommendations and precautions for just a fully informed healthcare team. I'm probably preaching to the choir, but one big thing I've been running into is nectar thick liquids. You recommend them and then you come in, it's a big old cup of ice in the nectar thick liquids. And by the time it's done, it's just a thin liquid. And then that patient will probably aspirate. So you guys could really come in helping with being more informed here of, hey, icing that drink, maybe not a good idea. The more people talking about it, the more the recommendations can be followed, and hopefully the patient can be protected. And this is when, do you guys have any questions?
So when they do aspirate during the test, I mean, is there going to be a danger of that, or like when they aspirate, is, are their lungs just going to clear it out by themselves, or you don't tell the doctor?
If they aspirate during the test, most of the time when they aspirate during the test, that's why we do our best to limit the size sips that we give down there if we start to suspect the risk of aspiration. But no, I mean, at that point, when it happens, you try to prompt them with either a cough or a throat clear. Sometimes that's effective of clearing it, but oftentimes if it's very severe and they don't have the feeling and it's even silent aspiration, which silent aspiration is just when there's no coughing after no patient response, it might fall on down. And at that point, that one little instant of aspiration, you kind of have to use your own clinical judgment of how far you want to push the exam. You don't want to keep filling it up, but you want to see what you need to see while you have them down there.
What about to progress them on their diet? You could do another swallow test. Like if they do bad the first time, or if they have to be on extra thick liquids, but then you think they're doing better, you have to do another one to see it on everything.
That would be so. That would also depend on the kind of aspiration, because there's not always. Ideally, you would want repeat imaging, but if they were showing overt signs, you took them in there, you figured out what was causing it, and you could assess the overt signs at bedside. A bedside might be sufficient if you feel like they have been working with therapy and getting stronger. But probably utilizing precautions too until you can get the imaging. But if you got them in for imaging and to get the sure thing to get the upgrade, if you had overt signs, you could use the bedside, but the imaging is probably the safest way to go once you've already recommended therapy off of the imaging to see the best progress.
So when we say like weaknesses, we're typically referring to like bringing the food down, like physical ability. Do y'all also put in like feed assist orders for like, let's say you're like cognitively affected stroke patients that need to use every single bite and like feed assist bringing the food down? How does that work here in inpatient rehab, and then how do you carry that over?
Carrying the feed assist?
Yeah.
Well, I know that we've all put in the order for the assist feeding patient order, and we usually, during the bedside, we're giving them cups to hold, giving them things to see how they manipulate them, and if they show any difficulty, we will put in the assist feeding patient order as well as talk to the nurse and say, hey, they're going to require feeding assist, or even if they're just weak, set up feeding assist. I've used that recommendation. But in terms of getting it to their inpatient rehab, what I've learned about is the nursing communication order that I've had to use sometimes to, in case there's a cross wire or something and they don't get it from the acute side, doing the nursing communication order. That way everyone's on the same page. They know what kind of precautions they're on. The precautions can range from how severe the swallowing trouble is, but if there are things you really need them to carry, that order is usually the best way to keep them in the loop with it.
So is that
Signs on the door.
you have specific things listed over there where like, because they're going to send a PCA in there to assist.
Right.
Is that like specifically listed like cues for swallowing? You see what I'm saying?
Like on the door, like.
How do you ensure like an OT is getting a referral? Like if we could come in and help with the feeding assist, not just the swallowing portion, but do you ever put like recommendation for OT services if you notice someone has difficulty?
With the feeding?
Yeah, with the feeding portion.
And in that instance, I mean, I have in the past, if OT, usually when we're seeing someone, OT has already seen them, but in the instance where the rare case where we come in and you guys haven't, then yeah, I will mention to the nurse if they haven't been seen by OT to possibly have that in, because we can usually see the feeding at the bedside. But then also, I know that there's things with them like their therapeutic potential. So if we see a lot of people that they're looking for like a least restrictive diet, and then you guys want to come in and work with them with therapy, they very well could need the diet, but then they might not be a good candidate for the OT intervention. So you kind of have to figure that in a little bit. But yeah, if y'all ever aren't in, I've just usually told the nurse feed assist, and you guys would do what y'all need to do at that point.
What Mike was trying to ask was like, how does the nursing staff know exactly what to provide during
What strategies to use,
Yeah, like
or like what to?
just physical, like the food, because a lot of times you walk in and they're just like literally spooning out, but not like on swallowing stuff like that.
For me, what I try to do if I leave strategies is I'll print out a copy of the strategies and leave them with the nurse so that they have them. Whether they refer to them and put them into action, you hope they would. And then I put them on the door before sometimes. And I think I've been seeing recently they've been a little more thorough with aspiration precautions on the doors, on the acute side anyway, for sure. But usually, yeah, providing them with a copy of the specific strategies, asking them if they have questions about it. If family's present during meals, the same thing. That'd be the step after the recommendation, is making sure that the patient's able to follow the exercise program or has someone capable of working with them on the exercises after. So, yeah, just giving them a visual aid mostly. Well, thank you guys for listening. Thank you guys for listening. Yeah. Yeah.